To the next talk, I invite Professor Vishali Gupta to enlighten us about 5 lessons learned on retinal disorders. And whoever is Monu's M34, can you please decline invitation to connect?
Thank you very much, Amit and Parul, for the kind invite. Well, correct diagnosis is three-fourths of the remedy, and over the next few minutes, I'm going to talk about 5 signs not to miss, which shall help in avoiding mistakes and making the diagnosis. The first sign is a clear dot sign, as you can see with the arrows out here. And I'm showing this sign because we do see patients on and off diagnosed as choroiditis. So if within a choroiditis patch you see a clear dot sign, it's more likely to be fibrin due to fibrinous CSR and not choroiditis. This is an example of a 28-year-old woman who was actually given anti-TB drugs and was worsening on steroids, and she was diagnosed as TB choroiditis. Now, if we look at those arrowheads indicating the clear dots, and we look at the configuration, this is a linear. Choroid by anatomy cannot be linear. So this is in the subretinal space, and she did have exudative detachments. And when you do fluorescein, the dots are hyper to hyper. Choroiditis will be hypo to hyper. So what was missed? The clear dot was missed, diagnosed as choroiditis, TB test done, came out to be positive, treated for ATT, steroids added, worsening on steroids. So how did we correct the mistake? We stopped all treatment, and this is what it was on stopping all the treatment. So then I also wanted to look what was the clinical picture. When was she misdiagnosed, or did she develop CSR after choroiditis? And this is the original picture. Actually, it was a straightforward multifocal CSR which had fibrin and which was misdiagnosed as choroiditis. The second sign which you should not miss is ILM drape sign. And again, the arrowhead indicates once you see this ILM drape, this is a sign of retinitis. It's mostly infective and mostly viral. Now, this is an example of a 14-year-old child, decreased vision in the right eye for last 3 months. You can see there are patches of retinitis as if retina is being eaten away. And you do OCT, you see this retina is eaten away. Please do not diagnose it as macular edema, because we have had patients diagnosed as cystoid macular edema. But if you see this break and ILM drape, this is viral retinitis, mostly due to measles virus. This is a classic case of SSPE, which is by and large misdiagnosed, and it can be very harmful. You have to do MRI, the brain lesions, EEG is abnormal, and generally these patients die within 3 to 4 months of the diagnosis. So the third sign, which is again not to be mistaken for uveitis, is rain cloud sign. Now this is the patient. You see it looks like retinitis. Howsoever severe the uveitis might be, it will not break into the vitreous. You may have overlying cells, but the retina would be intact. But once you see these cells breaking through, this is more of an endophthalmitis and not uveitis. This is an example of a 42-year-old man with a history of fever diagnosed as dengue. So we thought we were dealing with dengue foveolitis, and when we did the OCT, it shows the lesion coming from the choroid all the way in the retina and breaking through in the vitreous. This is rain cloud, a sign suggestive of endophthalmitis. So please don't treat these patients like uveitis, and this is how this patient responded. Just in passing, this is dengue foveolitis that does not break through into the vitreous, unlike endophthalmitis. The fourth sign is if you are seeing microcysts, which are in the nerve fiber layer, this is not macular edema. Macular edema is in the outer plexiform layer. Now, this patient actually was referred as macular edema, but you see, it's the nerve fiber layer which is thickened, and there are microcysts in the nerve fiber. So, if we go back to the patient, he was a case of a 24-year-old X-linked chronic granulomatous disease, which is supposed to have recurrent liver abscesses, and the patient was on lot of therapy for systemic diseases, itraconazole, Septron, Clox, and linezolid, and he developed this lesion. My first thought was this is a kind of probably fungus in the eye, and we did OCT, we found those cysts along with this. Now, these cysts in the retinal nerve fiber layer is not something you see in fungal endophthalmitis. And this is a very classic feature of linezolide-induced optic neuropathy, which causes RNFL microcyst. So we just stopped the treatment for this, which resulted in the recovery of these cysts. This last mistake is that imaging is fine, but don't lose your clinical acumen. For example, this senior bureaucrat from New Delhi has been receiving immunosuppression for 2 years and was advised biologic therapy, and that's how he ended up to us to start biologic therapy. We did optos. It looked like intermediate uveitis, macular edema, capillary leakage, but what was missed was these arrowheads indicate small cilia in the eye. Now, why should they be there? So we took the history. He said, oh, I am a mountain biker, so I had some hair falling into my eye 2 years ago on a hike. The cornea surgeon removed it, but after that I developed intermediate uveitis. So this was a patient we straight away took for the surgery, and there were 2 caterpillar hair actually lying inside the eye. He had cataract, and cataract was, you can see one of the hair being removed. He was off all immunosuppression, all biologics, everything. So when you are dead, you don't know you are dead. The pain is felt by others. Similarly, when you make mistakes, you don't know you are making mistakes, but it's sometimes costs patients very heavily. So it's important to learn from the mistakes and probably make new mistakes. Thank you very much.
Well, that was fantastic. I think such elaborate and beautiful slides. Professor Dogra, sir, for comment. Can we have a mic, please? Can we have a mic here?
We have those standing mics.
What Professor Vishali has just now demonstrated, and I always like her way of presentation. These are the cases which teach us a lot, and that is what stays always in the mind. And even if we can learn from each other's experiences, especially which are absolutely encountered during our own time, I think that's what she has shown very beautifully, and it's a great learning experience for all of us. Yeah.
Thank you, ma'am, for sparing the time and coming here, being busy in so many other sessions.